Action.
All right, so what we're going to do is y'all come on in here close. Don't be afraid. Nobody going to bite you hard anyway. Bite, but anyways,
John's gonna run
let
your
John
own.
up front so he can see.
I was wanting to do the C-spine on my knees.
Yeah, if you would, mind being my partner. Okay. So what we've got here is a patient. I'm going to do a rapid trauma exam or trauma assessment on this patient. And the first thing we're going to do is to scene size up. Remember that. All right, scene safety. Make sure you have the appropriate BSI and PPE on. And you're going to get up and you want to determine if there's any scene hazards. Make sure it's safe. And if it's not safe, make it safe. Then you want to determine the mechanism of injury, number of patients, and additional resources if necessary. And consider stabilization of C-spine, and that's what I'm going to do because this is a trauma victim. He was a pedestrian hit by a car. So I'm going to have my partner hold C-spine for me. And he's just going to hold the head there in a neutral inline position. I'm going to, at the same time, while we're doing this, at the exact same time, we're going to assess his level of responsiveness. And we're going to say, "Sir, are you okay? Can you hear me?" And he doesn't respond. So then the next thing I'm going to do is do a trapezius pitch. And he still does not respond. So he's unresponsive. So now my general impression of this patient is that I have a 30-ish-year-old male who's hit by a vehicle and he's unresponsive. And I'm going to consider him a critical patient because he's not responding due to the mechanism of injury. So he's going to be a rapid transport when we get to that point. So now that we've got this, we've got C-spine in place, we know our priority of our patient, we have the general impression of the patient, and I'm looking for any major life threats at this point. I don't see any right now, so I'm going to continue my assessment. My partner is holding C-spine, and he should be almost simultaneously at the same time opening the airway using a modified jaw thrust. And while he does that, I'll go ahead and insert an oral pharyngeal airway, or if he will accept it, and we'll say that he does accept it. Then I'm going to assess breathing. I'm going to listen and feel for breathing. I'm looking at the chest, and then I'm also going to go ahead because he has altered mental status, and I'm going to say he's breathing rapidly. It's alteration of breathing. I'm going to have my partner assume holding C-spine using his knees. And he's going to pretend like he's going to ventilate with a bag valve mask. Okay? So we're ventilating with a bag valve mask. So we've got airway breathing. And I'm going to look for other things that could impede breathing. Like I'm looking for, we know his airway's clear because we checked his airway already. But I'm looking for anything that could be wrong with his chest. So I would cut his shirt off. And I would look at his chest to see if there was like a flail chest or a sucking chest wing. All right, so now I've done breathing. So now I need to do circulation. I'm going to quick scan looking for any major bleeds. I've got clean gloves on, okay? So I'm going to look in the voids for any bleeding. And I'm looking at my hands when I do that, and I'm looking for blood. So I don't see any blood on my hands. I'm checking a pulse. I'm going to check a radial and a carotid at the same time. And I'm going to say he's got a weak rapid pulse. He's got cool, clammy skin. And I'm going to go ahead and assume treatment for shock by trying to keep him warm and ensuring that we've got good respiration going. All right, so now we made our priority that he's a priority patient. We, at the beginning, now we've assumed or assured that he is a priority patient. I'm going to start what we call the rapid secondary exam. So I'm going to work around my partner here. I'm checking the head for anything. I'm going to reevaluate the mouth, make sure that there's nothing in there. I'm going to evaluate his pupils, the light, evaluate the pupils. I'm going to check the ears, and you're going to keep bagging him for me. So I'm checking the ears. I'm going to move down to the neck, checking the neck for step off in the back, which feels like steps, and it shouldn't feel that way. I'm going to check JVD, make sure the trachea is midline, put a C-collar on, check the shoulders, check the clavicles, check the chest. Here I would auscultate the chest. Make sure everything good, rise and fall of the chest. Then I'm going to move down, checking the abdomen. check the pelvis, check the perineum, check for priapism, and then I'm going to check down. Now look how I'm checking the lower extremities. I have my hands offset. Because I know in the video they showed them doing this, I have my hands offset. You see here? My hands are offset. And see, I'm pushing. So I'm pushing here. And the reason I'm doing that is if there is a fracture, well, guess what I'm going to find?
It's a move.
It's going to move. If I do this, it may not. So I'm going to get down here. He would not have this on. I'm going to check pulse, motor, and sensory function. Same thing here. Check pulse, motor, and sensory function. Check the upper extremities. Pulse, motor, and sensory function.
He's coming too, he's getting back.
Pulse, motor, and sensory function. Now I'm going to check the back. Now on my partner's count, he'd go 1, 2, 3. I'm going to check the back all the way down. We're going to pull the backboard here and back
1,
again.
2, 3.
Back on here. We're going to secure him to the backboard. Going to get a sample history, baseline vital signs. He's secured to the board. We're ready to go. We'll do reassessment every 5 minutes and round. That's it. And that's slow. And that probably took
6 minutes.
6 minutes.